Hello, good evening, everyone. Welcome back to my IVF Fences and the European Fertility Society. We are back with our special guest today. Dr. Vladimiro Silva is with us. Hello, Dr. Silva. Welcome back. It's always lovely to have you here. How are you feeling, and are you ready to I hope we will have lots of questions and you will have a chance to answer lots and lots of them. So how are you? How is it?
Hi, Caroline. I'm fine. Once again, thank you for having me. It's always a pleasure for me to participate in these webinars with the European Fertility Society. We started them a long time ago during the pandemic, and so we've done dozens of
Plenty.
them. I don't know how many of
Yes.
them.
I didn't
but
count. Yeah.
yeah, it's really interesting for me, and I'm always very happy to be here. So
We are
I
always happy to
hope,
have you, for sure.
thank you, and I hope we can help all of those who are struggling to have a kid. And so please, to everyone who's watching, feel free to ask whatever questions you might have. I'm very happy to answer.
We are definitely happy to have you, as I mentioned. And today, let me remind those who didn't have a chance to simply join us before. So this is an online event that is anonymous. So anything that's on your mind, you can definitely type the questions in the chat so that Dr. Vladimiro can help you out with those. And from experience, we know that sometimes you will provide some of the details. Don't forget to put your age as well, anything that can help. But obviously, remember that this is an online event, and I know we always need more details. Doctors always need more details to be able to evaluate your situation, simply to provide a full answer. But of course, remember that today we will do it a bit differently. We don't have a presentation, but we will have like 5 questions that are most common questions. So we want to simply give you some time for your questions. We want to do it this way, and therefore we have 1 hour of questions. So Dr. Vladimiro has done it many times before. I'm sure he's ready to take any questions you have. And this is being recorded, so remember, you will also have a chance to rewatch it if needed, but I hope that you will stay with us. You will put all the questions in the chat, and definitely we are happy to go ahead with this. Let me just remind those who didn't have a chance to meet Dr. Vladimiro. He's the scientific and executive director of Fertility Centro in Coimbra in Portugal. So today our topic, as you know, is fertility treatment in Portugal. But there's another subject here, ask me anything. So definitely don't forget to simply ask anything that's on your mind and anything that you wish to have some answers for. So let's get going, okay, with those questions. I think we can go ahead. So the first one I will ask, so what is your advice for anyone trying to conceive? Let's start with that one. Yeah.
Okay, so a little kind of disclaimer before, a little bit to complement what you were just saying. It's what I will tell here are more or less, obviously, theoretical considerations. We've seen in previous webinars that people, sometimes patients, tend to ask questions about their own case. I will not run away from the questions, so I will address them directly, but please bear in mind that we don't have all the information and that these are all theoretical comments. Regarding your question, if someone is trying to conceive, what is my initial advice? That was it, the question, right? So the first thing here is to seek for specialized help. If you are below 35, you can wait a year to see if things happen naturally. Obviously, if there is some already known cause of infertility, like, for example, if you know that your male partner has a sperm count problem or whatever other problem in the sperm analysis, it makes no sense to wait, even before the age of 35. If you know for some reason that you have tubal blockage, we know that if the tubes are blocked, it's impossible to get pregnant naturally. IVF will always be required. If you have irregular cycles or if you have any other sort of already known problems like endometriosis, ovarian cysts, fibroids. I mean, there are lots of reasons why people know already that they might have difficulties to conceive. So if that's the case, it makes no sense to wait. If you are above the age of 35, you shouldn't wait for more than 6 months, because then we have to balance whether the need to know whether it makes sense to seek for help or not, but with the effect of the time. So we know that the later you ask for help, the more difficult it will be for us to help a certain patient above the age of 35. Obviously, 3 months won't make a difference, generally speaking, but 6 months maybe might make a difference. Okay, so overall, until the and another important thing, seek for specialized help, because obviously IVF doctors and clinics, they look at things in a different way, because that's what we do. It's our subspecialty, while GPs and gynecologists that are more specialized in other areas or are just general gynecologists, they don't deal with infertility cases every day. Okay, this is just, we are just more used to do it, either in public centers or in private ones, depending where you live. Okay.
Excellent, thank you. And let's have a look. I'm glad to see questions coming in, but let's have a look at the next that we have. So what are the most exciting developments in fertility treatment?
Well, sometimes this type of questions is associated with the hope that there is a silver bullet that will kill infertility. Unfortunately, that's not the case. Okay, we are this is a medical specialty that is kind of at the edge. So we're getting new things every year, sometimes multiple times a year, and so we've seen recent developments in many fields in IVF. So we nowadays we have artificial intelligence invading us in every step of the process. For example, we now can rely on very sophisticated systems to help us select our embryos. We have systems assisting doctors while developing the ovarian stimulation protocols, while establishing a prognosis for the patients. So we have all of that. We now have, we even have automated systems doing things like ICSI, embryo vitrification. So this is the future. I wouldn't call it exciting in the sense that none of this is a miracle, but we have a lot of new tools that will help us, that are helping us a lot in treating our patients. I would say that the best thing that we have is this accumulation of knowledge from everywhere and the access to the results of those protocols and so on. We are not doing the same protocols as we were doing a year ago, and a year ago we were not doing what we were doing 2 years ago. This means that science is evolving. We are learning from each other. Every time we go to a congress, every time a scientific paper is published, there is something added to this pile of knowledge. So we're learning a lot. Unfortunately, no miracles so far, but we are getting there slowly.
Okay, that sounds great. Today's topic is also about fertility treatment in Portugal. So let me go to the next question. So what makes Portugal different to other destinations for fertility treatment?
Well, I'm obviously someone. I'm talking about my own country and the country where I work. So what are the main differences between Portugal and the other countries? So first of all, we are one of the few countries that has open ID donors and donors because in some countries, for example, like the Netherlands, like France, like the Nordic countries and so on, many Central European countries, the law states that even Ireland and in a certain degree also the UK, the law in those countries, the law states that donors shouldn't be anonymous in the sense that children born from donations should have access to the identity of their parents at the age of 18. However, they don't have enough donors, and so people in those countries end up looking for treatments elsewhere. So in Portugal, we have the same law, but we do have a good number of donors. Actually, from our clinics in Portugal, we send either eggs or embryos to other destinations in the world, in Europe, but also in other countries for specific patient cases. And we also have a very progressist law. This means, for example, that in Portugal, the rights of the donors are very controlled and protected. The rights of the children born from IVF, for example, an egg donor can't donate more than 4 times in her lifetime. The amount of money that we pay to egg donors is fixed by law. It's 1,019 euros. It's the same for all public and private clinics. So it's a very clear system and transparent. Clinics are audited. We can't pay in cash. We only pay by bank transfer. So it's a very, for example, in the case of lesbian couples, for example, in some countries, the embryos obtained belong to the person who donated the egg, while in Portugal, the embryos belong to both elements of the couple. So that is important for ROPA or reciprocal IVF or shared motherhood cases. So we have a very patient-friendly legal environment. And we also have, from a technical standpoint, I believe that we are at the front edge of technology. We have nowadays all of the main clinics in the world. We all have the embryoscope, artificial intelligence, sample traceability systems. So the best culture media, the best vitrification techniques, and so on. So we have access to to the state-of-the-art technological conditions, like many other clinics in other countries. We have the advantage also of the cost being relatively low when compared, or let's say lower than in other countries, and we have this patient-friendly legislation.
Okay. That sounds good. Thank you so much. And before we go ahead with your questions, because there are plenty of those, keep them coming. But before that, this is a question that we also receive about open ID donors. Can you tell us where do they come from? How does it work at your clinic in Portugal in general?
Okay, we run a lot of campaigns in social media with universities, with local institutions where there are young people, okay? And this is a continuous effort of communication. So we're always doing online events, doing also field actions in places where students go. We work with the students' associations, we work with their teachers, we go to universities, different colleges, giving lectures and so on. And it's a continuous effort. So and so we were able to create a culture of donation. So we have donors donating their eggs and their sperm, and it is seen like a very favorable thing here in Portugal. Actually, before we have this open ID legislation, donors used to be anonymous in Portugal, like they are in Spain and the Czech Republic and so on. And we were very worried when the law changed. It changed from a day to the other. But it was very interesting because there were a lot of debates on national media and the press and social media as well. And we ended up seeing that all of the that high profile of the discussion around donor anonymity. So it became such a high profile topic that a lot of people were talking about that. And so we had kind of a paradox effect where donations peaked instead of having a drop. So, and actually, after the lift of the anonymity, so once we had OpenID donors, we never had as many donors as we have right now. It's kind of strange, but I think people also like the transparency of the process, and they want to know, because the difference between having an OpenID donor and an anonymous donor, with DNA banks these days, it's very easy to find out the identity of a donor. So you can either do it in a controlled way where donors receive proper counseling, where they are properly informed about the consequences and risks of donation and so on, or you can do it in kind of the savage way where donors are identified whether they want it or not. At least here, donors know what expects them. They have received proper counsel, and they are happy with that. And so I think that donors like that transparency, because that's what the previous system didn't have.
Okay. That sounds great. Thank you so much for that introduction, and of course those few questions. I think we can go ahead with the questions. There are lots of those, but don't worry, we still have more time and more time, so just go ahead and type those in. And let's have a look at the first question, okay? So I would be interested to hear your view regarding PGTA results. My last cycle was abnormal result. This cycle, I had a chaotic embryo. Are you able to give your thoughts? I haven't received the report of the chaotic yet, although I have asked and am waiting to see the doctor. And sorry, there's one more thing here from Cynthia. So what would be your approach with that result in your clinic?
So can we put
yes,
the
I
question?
Can you know.
Yeah, I think it's easier. Yeah. Okay. So what happens when we what's a chaotic embryo? A chaotic embryo, it depends a little bit on the classification from the genetics lab, but typically it is an embryo with several aneuploidies. So what's an aneuploidy? It's an embryo with the wrong number of chromosomes. So when we have multiple abnormalities, meaning, for example, an extra chromosome, let's say on the 14, less of a chromosome on the 6, typically some labs classify it above 6 abnormalities. Some others classify an embryo as chaotic above 4 abnormalities. It really depends on the abnormality threshold that is used by a given lab. So having a chaotic embryo, typically it is age-related. I don't know how old is Cynthia. Unfortunately, there's not much that we can do here unless we try again. Okay, having a chaotic embryo if it was just one abnormality, it would be enough to reject the embryo. Having multiple abnormalities, it means the same. Okay, it's a random event. It's very related with the age of the oocytes. Obviously, some women that are younger can also have the same problem. Here, what we would do is we would need to assess the case. How old is this patient? How many times has she tried before? Does she have a normal karyotype? Also, the male partner should be assessed by, in genetic terms. We need to make sure that he also has a normal karyotype. If everything is okay, if they are doing, if she is below the age, what's her AMH level and other hormones, obviously. So I would say that if her ovaries are still working and replying to the medication and responding to medication, I would say that we can try again. We would try to optimize the ovarian stimulation protocol. we could try to accumulate eggs or embryos in order to have more embryos, because apparently she only had one. Obviously, the more embryos, the more eggs we get, and the more embryos we get, the higher are the chances of having a normal embryo. But at the end of the day, we would need to try again, either in a single stimulation or in multiple stimulation cycles, accumulating eggs or embryos, doing consecutive stimulations, or doing one stimulation per cycle. So it's, I mean, there are many options, but it's always the same. Try again. Obviously, if this is a case of a patient whose ovaries are no longer responding to the medication, if she's above a certain age, it's important.
A follow-up there, yeah.
Sorry, I lost I didn't see the previous
sorry,
one.
this is just the follow-up from Cynthia, so I just wanted
Was
to
karyotype or
see.
karyotype
Yeah.
that you said, please? No, karyotype, the second one. Okay, the karyotype. So it's the genetic constitution of a person. So all persons have a karyotype if it is normal. I mean, the chance of it being normal are more or less 98%. Okay, so it should be normal. This is kind of a screening evaluation that we sometimes do in certain cases. Obviously, if this is a patient whose ovarian reserve is very low, if she's above a certain age, typically above 43, which probably would consider this as being related with ovarian aging. We can try again, okay? If the ovaries respond, we can always try, but then we have to balance the cost and the benefits, and then next step would be obviously think about egg donation.
Okay, thank you so much.
And good luck,
Thank you
Cynthia.
from Cynthia. Definitely. And of course, if there's anything else, you know what to do. Let's have a look at the next question we have here. So at your clinic, would you transfer high-level mosaic embryo?
I mean, there are recent studies that were published actually last year, where that have shown that until a certain level of mosaicism, the chances of implantation are pretty much the same. So what is happening is that genetics labs are, in principle, only reporting. So they will only. They don't report whether an embryo is a mosaic or not. They will just say this embryo is good to transfer or not, based on the evaluation that they have done internally to their pool of embryos. It's also done with artificial intelligence and learning from previous cases. In practical terms, what does this mean? So nowadays, the tendency and kind of the consensus worldwide is that mosaic embryos, at least until a certain level, have the same type of prognosis as non-mosaic embryos. And so mosaicism can't be valued or seen as a negative thing, because what we have seen is that it really doesn't affect the chances of pregnancy. And so in that term, yes, I would trust mosaic embryos if the genetics lab where I'm doing the test advises me to transfer the embryo. That analysis is made by the people who has detailed access to the genetic content of the embryo, and it's based on thousands and thousands of cases that they have done and reviewed according to their algorithm. So we need to trust the system, and that's what we do. Okay.
Okay. Thank you so much indeed for yet another answer. So is it possible to do embryo banking in Portugal?
It is for PGTA. Okay, so in Portugal, what the law says is this: you can you cannot create new embryos when you still have frozen embryos, unless there is a strong medical indication for that, and doctors need to justify. One of the accepted justifications for that is obviously doing a PGTA cycle or a PGTM or a PGTSR. So if you are doing genetic testing or genetic screening, you can accumulate embryos. If you are doing embryo banking for the purpose of preserving your fertility, you're not allowed to do that. Okay, so, but in those cases, even if we were allowed, we would always suggest egg freezing because it's much more flexible. Nowadays, we're having survival rates above 90% in a consistent way. We're actually certified with the best practices of vitrification, and a lot of clinics worldwide are having this level of proficiency in the egg freezing technique. So it's very reliable, the egg freezing technique, and so there is really almost no reason to freeze embryos instead of eggs. We do it in PGTA cases. In some of them, in some others, we don't do it. It's really a question of evaluating.
Okay, brilliant. Okay. Thank you so much. There are some questions on PGTA, PGTS, PGTM actually as well. So let's have a look at them. So can you tell more about the process of PGTA? Tests, yeah, PGTA tests and process.
Sorry.
Sorry, just let me show you. Sorry.
The PGTA and PGTS tests. So first of all, these mean more or less, these mean the same. Okay, so PGS is the acronym of pre-implantation genetic screening. We used to that was used in the past. It was replaced by pre-implantation genetic testing for aneuploidies, which is PGTA. Okay, so how does it work? Typically, so what's this? We create the embryos, we culture the embryos until day 5 or day 6, typically. This means until the blastocyst stage, where the embryo has more than 100 cells. On that day, we use a laser system. We do a hole in the embryo, and we take around 5 to 10 cells out of the embryo. Then we freeze the embryo, okay, and we send this, we prepare those cells and send them to a genetics lab to be analyzed. Then we will be able to say this embryo has a normal constitution or not. Why can we say that? Because we take those cells from a part of the embryo that is called the trophoectoderm, which is considered to be representative of the whole embryo. These cells will later form the placenta, so it's actually not the embryo itself, but according to multiple studies that have been done through the years in many countries, those are the cells that are more related to the true genetical content of the embryo. But obviously, this is a sample of 5 to 10 cells. It's not all the cells of the embryo, okay? So, so this is, sorry, just 1 second. Okay. So then another, and I think that's, so what are the cases in which we recommend PGTA? So we advise patients to do PGTA when they are 39 years or older, when they have tried and failed IVF cycles at least 3 embryo transfers before. So if we've transferred them at least embryos, if we've done 3 embryo transfers without a pregnancy, then we recommend PGTA. Also, if they had 2 miscarriages before, or if they had an affected pregnancy with for example, a trisomy 21 pregnancy or whatever other abnormality, genetic abnormality in the past. So if that has happened, there is a clear indication towards PGTA, and we advise patients to do it. This is also the legal conditions to go directly to PGTA in Portugal. If we need to do PGTA for reasons other than this, we need to submit a request. The authorities are usually fast while replying to that, but this covers pretty much all the cases where there is a clear scientific indication towards performing PGTA.
Brilliant again. Thank you so much. Now let's talk about PGTM. This next question on this. So Fabia said that I have a rare genetic disease. And
okay,
what are the regulations for
can you
PGTM?
put it?
Yes,
Can you? Yeah, PGTM. Okay. So there is a list of genetic diseases that are immediately authorized to do PGTM. So what is this, just to explain to everybody? So there are, when we test the embryos for genetic diseases, we can test them for chromosomal abnormalities that are usually age-related, or we can test them for what we call monogenic diseases. These are diseases that happen in just one gene. It's probably what is affecting Fabia, and those some of those diseases have a high chance of being transmitted to their kids. So typically, the first step is to identify the disease in question, identify the risk. It requires a genetic consultation with a medical geneticist, so where he or she will tell the patient, well, you have this disease, the chances of this being transmitted to your children are 50%, 20%, wherever, and these are the potential consequences of this disease. Having said, then we can test, we can create the embryos, look for the embryos. So we do the same as for PGTA. We culture the embryos until day 5 or day 6. We do a biopsy, so we make a hole in the embryo. We take 5 or 10 cells out of the embryo, and we go and analyze those 5 to 10 cells. If those, if the affected gene is contained in those cells, this means that the embryo is a carrier of the disease, and so we can't transfer that embryo. If the embryo is not a carrier, that means that it is a healthy embryo. We also test it for PGTA, so to make sure that, for example, an embryo doesn't have Huntington disease, but it has Down trisomy. Okay, so we need to make sure that chromosomal numeric abnormalities are also excluded, and so we classify this embryo as viable. What is the law around this? In Portugal, we have a list of hundreds of diseases that are pre-authorized. So if a certain disease is published in the public list of genetic diseases for which there is no need to place a special requirement to do PGTA. So we don't need to submit, we can just move on with the treatment. Obviously there are thousands of genetic diseases, some of them are extremely rare. If that's the case and the disease is not listed, we need to submit a request to PGTA. IVF authorities are very fast replying to this. Obviously, they only authorize diseases that are related with significant risks and suffering, because in some cases, I mean, in Portugal, to be honest, I never had a rejection of a PGTM request, and there are hundreds of diseases pre-authorized. Obviously, we don't know if there are some borderline cases. It never happened as far as I know, but so we always, it's not me who decides, so in a certain way, we always have to ask for a permit.
Okay, that sounds good. Let's go to a different topic this time. So, is there a specific protocol you use for those with KIR HLA mismatch, KIR AA myself, HLA C1, C2 for partner?
Okay, so first let's explain what is this to everyone else. So there are some antigens in the So the uterus has some receptors. Those are called the KIR, K-I-R receptors in the uterus, and they can be AA or BB, for instance. If the uterus has the KIR AA receptors and the baby has the HLA-C2 genes, there is what we call an incompatibility, a mismatch, it's a good word actually, between the embryo and the uterus that can trigger an immune rejection reaction that can trigger complications like implantation failure, early miscarriage, spontaneous miscarriage, or complications later in the pregnancy, like preeclampsia and some other immune triggered reactions. What can we do in those circumstances? If we are using donors, we can try to use donors who are not the carrier of the C2 gene. If that's not possible, and that happens, we have special protocols. Unfortunately, there are lots of protocols. These are relatively experimental. Okay, so just to make it clear, there is no consensus in the scientific community on this here HLA theory. There are there are obviously those doctors and clinics who strongly believe in this. They are completely in favor of they are completely in favor of testing these, and they have protocols for that. But it's not. There is no consensus. We have specific protocols. Typically, they involve aspirin, heparin, growth factors. So it's a complex protocol, prednisolone, that we use. Different medication, different stages of the protocol. The most important are the growth factors. Apparently, these are the medication that has shown better results. We have that. We have lots of babies born from patients who are KIR AA, and where we have a mismatch. Okay, so it's not kind of a death sentence. It doesn't mean that you will never get pregnant. It means that you are that it will be more difficult. Okay, but we have a lot of protocols that we use for that, and we have a lot of babies. Yes, of course. That's what I was saying. Growth factors, Neupogen is the most. I'm answering Natalia right now. This is the most used medication. That's the medication that has been more effective in these cases. Okay, where we have a KIR-HLA mismatch. So we definitely use that. Obviously, we need to take a look because this medication has a lot of implications in other parts of your body. It can have other implications in your health. So we need to make a proper assessment. But yes, this is one of the most used medications for these cases.
Hey, thank you so much. This is never an easy topic for sure. Thank you so much for answering that one as well. Now we will go again to a different topic, but this is Ask Me Anything today. So now there's a question about egg freezing actually. So let me just show you here. So I'm considering going to Portugal to freeze my egg. How would the process go normally? Can I do some tests here before, and which ones, how to schedule collection?
Okay. Yes, you can do the process in Portugal. Typically what we ask these patients, we book an online consultation with one of our specialists. We ask the patients if they already have done some some bloods or exams in their country of origin, they should send it to us beforehand so we can take a look before the consultation. If not, we will just address it during the consultation. So we will give the patient a list of tests, and yes, she can do it in her country of origin. The problem here is Germany as a country, because in Germany, IVF doctors are very limited by law, and normally they are not very keen to collaborate with foreign clinics in these type of processes. But if you find a doctor who can collaborate with you, then we can certainly start the process. And we have done that with many patients, okay? But our experience with German patients is that it is never easy. Okay, it depends on the personal relationship that patients have with their own doctor. So if they have a good relationship, they can do the initial tests in Germany. They can even start the process there and do the first control scans in Germany, traveling to Portugal directly for the egg aspiration. Typically, they arrive here a day before, so we can assess them, and then we do the oocyte aspiration, and the next day, and then the patient is good to go back. What EF is asking is if it is better to go to Portugal to do all tests and then back to collect. If you have some difficulties relating with in your relationship with your German doctor, yes, it will be easier. Okay, because then we can evaluate you, we can do you a scan ourselves, medication probably will be cheaper for you as well. It will be easier to do the bloods and so on. So it's an option that will certainly save you time and money. I mean, even considering the costs of traveling, I mean, depending on, because in Germany they have what they call the Krankenkassen, which are it's kind of a health insurance where and patients have different rights according to the type of insurance that they have. So sometimes foreigners living in Germany, they don't have access, they don't have the right to have that, and then medication can become very expensive, like 2,000 euros instead of 300, 400 or 500. So that alone will pay for the trip to Portugal. So yes, it's a possibility, but the fertility preservation process itself can be very straightforward because we use methods that are safe, that reduce the risk of hyperstimulation, which is the main side effect, to less than 1%, which means almost zero, and it is a very effective and easy to organize type of treatment.
Okay, thank you so much indeed for that. If there's anything else, you know what to do, but I think it was pretty clear. Let's have a look at the next question. I will show you here. Just we have some few details. 39 had 4 transfers, but not even an implantation, medium quality embryos. So 2 of the blastocysts was checked, PGTA and healthy. Blood values are okay, hysteroscopy, okay, immunology checked here, and genetics too. What else can I check? Is donor eggs a possibility, or will that not work either?
Well, it's a difficult case because in this situation there was a transfer of 2 healthy blastocysts checked, confirmed by PGTA. Okay, so if we are transferring euploid embryos and we're not carrying a pregnancy, then the problem is most likely on the uterine side. There are things, for example, in this list that we would check if it was at our clinic. For example, the microbiota. Sometimes patients have chronic endometritis or local infections or just an imbalance of the bacteria inside the uterus that can cause local inflammation and keep the embryos from implanting. That's one of the cases. In some cases, we need to take a look at the ovarian preparation protocol. Some patients respond better to, for example, natural cycle or modified natural cycle protocols. In some cases, we need to, in order to get a good endometrial thickness, we will need to do some special protocol. So there is a lot that we can take a look at. It's, for example, the window of implantation is something that was kind of initial. If this conversation would take place 5 years ago or 3 years ago, everybody will be talking about the window of implantation and how important it is. Then, more recently, there were some studies done on unspecified populations. So they were doing window of implantation testing to all patients without a specific indication and concluded that it was pointless, and it was not associated with an increase in pregnancy rates. However, we know that for very specific groups of patients, that can still play a role. So, I mean, having all of this history, I would definitely take a look at that as well, and maybe there's something else that we are not seeing here. Okay, so treatment protocol, microbiota, eventually also window of implantation, ultrasound scan to check for the characteristics of the endometrium after stimulation. We would also try natural cycle, maybe. So there are a few things that we can take a look at, but answering the last part of the question about donor eggs, I mean, we were not having a pregnancy with euploid embryo. So I would say that it's unlikely that the result would be different with donor eggs. So I would try again with the patient's eggs. I would do PGTA. If the embryos are healthy, then we would think about what to do in order to optimize the uterine conditions. Okay, I wouldn't transfer those embryos before we would have ruled out all factors. And sometimes, and the reality, I remember specific cases of patients. I mean, I could spend the whole night here talking about those stories. Where patients were having results like this, and from a moment to the other, they got pregnant, and we don't know why. Okay, sometimes there are factors that we don't control, and medicine is not aware of them. So, but again, I would say that if Eve has only done what she mentions here, there is something else to be done, but we would need to take a proper look.
For sure, because as you know, definitely more information is needed, of course. Let's have a look at the next question from Mark here. So which type of genetic test is required for men with egg donor treatment? What is the reason for this?
Okay, so this is a very interesting question because the answer can be quite complex. So the first type of what we are advising all patients right now is to do the carrier genetic screening tests. What is that? We are all human beings, we're carriers for recessive genetic diseases, okay? I mean, even if you are a normal, healthy person, you are certainly a carrier of 4 or 5 or 6 diseases that don't affect you, but can be transmitted to your children. So when we are assessing egg donors, we are testing the egg donors for their karyotype, and then we're also screening them for the most common genetic diseases. Typically, at our clinic, at least egg donors are tested for around 70 genetic diseases, but there are thousands, more than 4,000 genetic diseases that are well known. So we can upgrade this testing to packages of 570 diseases, or even to packages of more than 2,200 diseases. How is this done? So we already have the DNA from the donor. the results from the amplification of that DNA are in a black box. We don't know those results, and so we test the male partner. We do the same type of amplification. Let's say, for example, Mark wanted to exclude 2,200 diseases. We would amplify his DNA, send it to the genetics lab, and then they will say, Mark is certainly a carrier of 4 or 5 diseases. The donor is certainly a carrier of 4 or 5 diseases, as all human beings are. And the results that we would get would be these persons are the genetic matching is favorable or is not favorable. If it's favorable, it means that whatever diseases Mark is carrying and whatever diseases the donor is carrying are not the same. So we can exclude all of those 2,200 diseases. Well, it's not correct to say this. We can exclude all of the more than 50,000 variants of these 2,200 diseases, because there could be more rare diseases that are not included in, more rare mutations or variants of these diseases that are not included in the package. So even by testing more than 50,000 variants, there are still a few variants associated with those diseases that are not included in the package. But for those 50,000, we can say these are excluded, okay? And the reason why these 50,000 have been selected is because they are the most common between the very rare diseases that we test, okay? And so this is one example of why do we recommend the male partner to do it, because if you're doing egg donation, you're already introducing in your family DNA from someone else. So if you can increase the safety of the process to be more reassured, then we should do it, because it's a lot safer for the patients. Sometimes we already know that the donor is a carrier of disease A, B, and C. Obviously, because she's human, she's been tested before, she's been matched against someone else, and we've accidentally found out that information. This doesn't mean that the donor is ill. It only means that we already, instead of doing it blindly, like we were doing in the past, we already know some of the diseases, and we know that these have been excluded. So it's actually the opposite. For example, if you're using a donor with a carrier of cystic fibrosis, it's actually safer, because you know that your child will not have cystic fibrosis because it has been matched against the male partner, and if there was a mismatch, we wouldn't use that donor. Okay, the matching report will be negative. Another situation where we can test the male partner is, for example, if a patient has a long history of miscarriages, or bad embryo quality. I mean, for whatever reason, if there is according to the medical history, if there are reasons for us to exclude the risk of having a genetic abnormality, sometimes we ask for the karyotype of the male partner as well. In some clinics, they test it from the beginning. We sometimes test it from the beginning, depending on the medical history of the couple or the patient.
Like, makes sense. Again, thank you so much for coming in, Mark, as well, and for asking this question. Definitely interesting one. Now we will go to a very long question with lots of details. So I will just try to, I will show it to you so you can see there are plenty of details. But basically, what could explain early fragmentation of many embryos? Patient is 40. As you can see, 2 IVF, 2 different clinics, 2 different countries, 2 different donors, 2 different protocols. You see the details. So each time almost all fragmented on day 2. None reached the stage of blastocyst. It was suggested it might not just be age, chromosomic issue, maybe that the oocyte quality was affected with a high level of hormones. What is your opinion on the reason of this early fragmentation? What's different would you suggest?
If we are talking about a treatment with own eggs plus plus donor sperm, I would say, so first of all, early fragmentation is very, especially if it's early, is very associated with egg quality, because the male factor. I mean, obviously, if there is a problem in sperm, we will even have fertilization failure. But typically, it's from day 3 onwards that we see the effect of the male factor. So in the first 3 days, the embryo development happens. A big proportion of that is thanks to the quality of the egg. It depends on the quality of the egg. What I'm seeing here is that, for example, in this initial protocol, the ovarian stimulation was not very aggressive. 225 is not a very aggressive dosage. 6 embryos is not a very high number of embryos, so I wouldn't call this, I definitely wouldn't call this an aggressive stimulation. Then the patient did initially this was a short protocol with Benfola and Fibromatel. Then they moved into a long protocol, so with Decapeptyl, Pargovaris 375. That's already a high dosage stimulation. No surprise that it ended in an hyperstimulation. 9 embryos. Okay, it's a good number. Okay. So, I mean, probably we can optimize the ovarian stimulation using a high dosage, but not the long protocol, in order to avoid the risk of ovarian hyperstimulation syndrome. Then we can do the embryo culture in the best possible conditions, in the embryoscope, with the best culture media, and see what happens. If we don't have a blastocyst again on a 3rd cycle with truly optimized conditions, I would say that it's preferable to think about embryo donation or egg donation. We can also try, because there are some theories that say that in a mild stimulation protocol we will only get 1 or 2 eggs, but they can have better quality. We can try that approach. It's something that it's more of, I mean, 10 years ago a lot of people were defending that. Nowadays there is a relative consensus that trying to have a good number of eggs and then the highest possible number of embryos is associated with better results. Okay, so these mild stimulation theories are more or less from the past. These days the tendency is to do short protocols with agonist triggering in order to keep the patients from having the ovarian stimulation protocol, and try to get a good number of eggs and see how it goes. So I wouldn't throw the towel on this case. Okay, I think there is room for improvement. None of this stimulation was good. The first one was probably understimulated. The second one ended up in a hyperstimulation. So maybe a well-balanced stimulation could provide better results.
There's also only follow-up here from the same patient. So do you think age is the main issue, or I have the same problem when I would have the same?
Age is definitely an issue. Okay, we can never say that age is not an issue if you are over 35. It's for some patients it's a bigger issue than for others, but it's always an issue. We don't know if she would have the same problem when she was younger. I think we should focus on what we have now, and I think that now there is a fair chance that this ovarian this ovarian stimulation can be optimized. Okay, so I wouldn't. I mean, this is not criticizing other clinics' work. Obviously, it's learning from the reaction to the previous cycle. Okay, sometimes we also need to learn from cycles where we didn't have a good response from the ovaries of the patients. So what I think here is that this patient, she had she had this experience, and it's a good learning opportunity for the doctors who are dealing with her, because clearly these stimulations can be improved. So if she does an improved stimulation and results are the same, then I would say probably it's better to think about egg donation. Uh, I'm not, before that, I wouldn't say egg donation immediately, unless obviously she says, well, I don't want to go through another ovarian stimulation again, and so on, because it's acceptable to move on with that, and I just want to have a kid. And it's a different strategic approach. It's also a very personal decision. But I would say that in principle, from a just medical cold medical standpoint, I would say it's worth trying again with a different protocol.
Excellent, as always. Thank you so much. We will be slowly finishing, so if there's anything else you wish to ask, go ahead. This will be the final call. And I will now go to a few questions, actually, because they are quite similar. Okay, so there's a question from Natasha, but also Mina, and this is about 47. Both wrote that at 47. So will you treat someone with Onyx just to, even there's a tiny chance of success? And the second one from Amina, I'm 47, so can I do IVF with donor eggs, low ovarian reserve? So what are my chances? What the percentage of
So
chances?
it's all about informed consent. Informed consent. So what we normally do, because we get a lot of requests from older patients, is this. First of all, we test the ovarian reserve. Okay, it's important for us to, and then we decide according to that. If, for example, we have an AMH of 0.5 and FSH of 3 or 4, we can try. Okay, if the patients understand that at the age of 47, chances are really low, we're talking about 1 or 2% maximum, and they still want to go ahead, fine, we won't deny them that possibility, and we will do our very best to take it to the limit. Okay, obviously, if a patient gets to the clinic with an AMH of 0.05 and an FSH of 43, that actually happened, we will not do it because it's impossible. Okay, it's maybe in the next cycle the situation changes, but at that moment the ovaries will simply not respond, and so it wouldn't be ethical to do an ovarian stimulation in those circumstances. So what we do in these cases is this: we evaluate if there is a theoretical possibility. As low as it is, we discuss it with the patient. If the patient accepts the risk, understands the odds, we can go for it. We won't cut her legs on this, but we know that it's unfortunately relatively unlikely that we can find that we can obtain good results after that age.
Thank you so much. There was Sally also added, 1.1 AMH, and she's also 47.
Okay, 1.1, if we are talking about nanograms per milliliter, it's a very good result, and we can probably try. Okay, if it's picomoles per liter, it's very low. Okay, so it will depend. Okay, there is also a question here from Christina.
Yes, I wanted to show you this, so don't worry, I
Okay.
have it here. So let me just show you. So yeah, my question, my problem is to keep the water in my bladder during transfer. What can I do to help myself to wait enough time after transfer? I was using egg donors, but I think that's my big problem, or maybe it's not a problem. Does that affect pregnancy?
Well,
This is the
it will
second question.
depend on the doctor, okay, that does the embryo transfer. For example, at our clinic, some of the doctors actually prefer to do it with an empty bladder or a half full bladder. Some others prefer to do it with a full bladder. It's possible to do it. It's very related also with the personal experience of the doctor. For example, our clinical director, she's someone that has a lot of experience and a lot of she has that touch, and so she prefers that the patient have the bladder empty, because she can do it in a better way if the patient has it's easier for her. Some other patients prefer the patients to have the full bladder, because we can do an ultrasound and it's easy to spot the cannula that is doing the embryo transfer. So I would say that in the first line, I would say this is a question that depends on the doctor that is doing the procedure. And sometimes if the patient is not comfortable, we find a way to do it. It's a question of dialogue. I would say to Christina, talk to your doctor, discuss this with him or her, and I'm sure they will find a way, because patients need to be comfortable. That's what we do.
Definitely. That sounds about right. Thank you so much.
Okay.
One more question here. So what does the embryo testing affect the quality of the embryo? Does it hurt the embryo, when you puncture it to take the cells for testing?
Okay, that risk exists. Okay, I would say it's a very low risk, certainly below 2%, but it can exist. Okay, it's an invasive procedure. We are making a hole in an embryo. We are taking 5 to 10 cells, but doing that, if it is done by an experienced embryologist, and for example, at our clinic, all of the embryologists that do PGTA are certified to do that. In order to be certified, they need to go through a training program. They need to do it in disposable embryos many times with other more senior embryologists by their side. So so it requires a lot of expertise from the person who is doing it. Obviously, it requires the availability of good equipment, good laser system, good microscope, and so on. So I would say that in good embryos, chances are very low, but they are not zero. Okay, so yes, there is a certain risk. I would say 1%, less than 2%, maybe 1% of chance of losing the embryo.
Okay.
There,
Sorry, you can see the follow-up here, right? So we talked about IVF at 47 with own eggs. How about egg donation? Let's clear this as well.
Yeah, of course. At the age of 47, there is a clear indication towards egg donation. Okay, egg donation is legal until the age of 50, not including 50. So 49 years and 364 days. Okay, so yes, at the age of 47, it is actually the best way to have a pregnancy is to go through egg donation, undoubtedly.
Thank you for the clarification here.
Okay.
And while we are on this topic, there's one more question that we will be finishing, but I think we can still have a look, of course, at this. And we talk about egg donation. What is the availability of diverse ethnicity donors in Portugal? Are there restrictions for who can use donor eggs? And is it more expensive than in the UK?
Okay, so thank you for your question, Craig. So availability of diverse ethnicity donors in Portugal. We have a good availability. I mean, this is obviously an image of the country, because we have we have a multicultural naturally there are phenotypes and groups where it is more difficult for us to find donors. For example, we do have a lot of donors of African origin. There's really no problem for us. We have a very good number of Black donors, of donors, mixed race donors, a lot, really no problem with that. Obviously, people like me and maybe you. Because I mean, I'm a typical Portuguese person, so the majority of our donors are actually like me. Yes, there is somebody else asking if we have Black Caribbean. Of course we do. So really no problem at that level. our difficulty is with Asian donors. Okay, we struggle to find. I think it's kind of cultural because Asian origin communities are less prompt to donate. We don't know why, but we obviously also have our own Asian origin donors from time to time. Indian donors, for example, at the moment we do have Indian origin donors, but we don't have. Asian origin, Asian in the sense of China, South Korea, Japan, all of that. So that's our main difficulty for now. But yes, so aside from the Asian donors that South Asian donors, let's call it, that are really difficult to find, the rest we are okay. We don't have waiting lists and we have a good availability of donors. Then the second part of the question was, is it more difficult? Can you put Greg's question
Yeah,
again?
sure.
Sorry,
Just
I
let me
forgot.
show you, definitely.
Okay. Are there
Restrictions who can use. Yeah.
donor X? No, there are no restrictions. Okay, we can use. I mean, wherever the donor. So no restrictions aside from the restriction of access, normal restrictions of access to treatments. If it is more expensive than in the UK, well, I don't know the price of all UK clinics, but it is typically way less expensive. Okay, in Portugal, an egg donation treatment, at least at Fertility Centre, costs 7,500 euros, where in the UK it can cost up to £10,000 or something like that. So it's definitely less expensive than in the UK, and there are no restrictions of access.
That's great. One more question. So can you bring a donor from a bank such as Cryos?
Yes, and as long as it is an open ID donor, it's a legal requirement. A sperm donor from Cryos, yes.
Sperm donor,
yeah. So yes, we can. We work a lot with Cryos or the European Sperm Bank as well. So as long as it is an open ID donor, because in Portugal we can't do anonymous donations, and as long as the donor doesn't have adult photos, because those are not allowed in Portugal. Okay, we can work with baby photos, with photos from other ages of the donor, not adult photos.
Okay, crystal clear again, thank you. One more, I think, final short question. This is from our patients regarding egg freezing. So how long does the egg freezing process take?
So egg freezing, it will depend. Okay, so if you do everything here in Portugal, it takes 2 weeks. Okay, you have your period, and then you do the ovarian stimulation. Egg collection typically is done on day 12 to day 14. So 2 weeks, roughly speaking. If you live elsewhere and you have a doctor who can support you, you can do everything in your country of origin, and you just need to travel to Portugal at the final stage. Obviously, for this to be possible, we need to validate it. We need to make sure that we receive all of the relevant information, and so that's it.
Okay, brilliant. Thank you so much. One more question in the meantime is here. I think we can still answer. Just let me show you. So basically, it's about how much does a complete fertility test cost?
I mean, it will depend on exactly what we need to test. Okay, so let's say. Let's say, for example, that it's a very standard case. I would say a doctor's appointment costs 110 euros, and then the bloods in the lab, it can be around 200 to 300 euros, depending exactly on what we are testing. And that's it. Obviously, if you need to do an MRI, or if you need to do an hysteroscopy or whatever complex traditional testing might be necessary, these are unlikely, okay? But I would say 300 euros in bloods, probably less than that, plus the cost of the consultation.
That's great. Thank you so much. In the meantime, we did receive short questions, follow-ups actually.
Okay,
So I'll be
yeah.
going, it's from the same patient regarding the egg freezing. I'm going to, from Germany to Portugal. Info would needed, it would, sorry, would it be needed in German or English is okay? I mean, I believe you
Yeah,
have.
it can be in either language. We have native speakers for German. We have 3 native speakers for German at our clinic, so no problem with that. Obviously, English is the common language everywhere, so it can be in one or the other, no problem. No need to translate from German to English. Give it back to
Thank
you.
you. So how many days, sorry, do you check the uterus during the 2-week stimulation cycle?
It will depend. Typically, on an ovarian stimulation cycle, we do the first scan between day 6 or day 7, and we then do it every 2 or 3 days, depending on how it is going. So I would say on a typical cycle, we would check it at day 7, and then again on day 9, and we would trigger to do the pickup and the aspiration on day 12, or maybe we check again on day 11 and do the aspiration on day 13 or day 14. It will depend on how the ovaries are responding. The purpose of this control is actually to adjust the medication, to see if things are going well, and also to define the best date to go and collect the eggs. Okay, so there is a certain uncertainty at the end. There is some uncertainty at the end of the stimulation, because that's exactly why we need to control. We can't anticipate exactly how it's going to be. So I would say 3 to 4 controls on average.
Excellent. Thank you so much. As I mentioned, we will be finishing, but I think we can still handle this one. Okay, the last one. So it's about egg donation. Are you allowed to know weight, height, hair, and eye color of a donor for embryo donation?
Of
Embryo
course.
donation, sorry, for embryo
Yeah.
donation. Yeah.
Yes, this is some information that we, so just a little context. So embryo donation in Portugal is a little different than in other countries, because clinics are not allowed to create embryos for the purpose of selling them. For example, in Spain, clinics can create embryos to sell. In Portugal, we can't do that. But we tell the story of, so donated embryos are surplus embryos that were donated by other patients. So typically, we tell the story of the embryo. It's like, for example, this embryo is from an egg donation cycle that used donor 1, 2, 3, 4, 5, and here you have the full profile of the donor, and we can even give you a 6-page document where you will know everything about the donor. But regarding the male partner, it was the husband of the couple, and we can only tell you that he is 1 meter 82, blonde, brown eyes, B positive, B plus, weights 83 kilograms, whatever. Okay, so it's something. So we would give that information. That's what we have, and it goes like that. Obviously, in some cases, we have more information available. If the embryo comes from a double donation, we can even give you full background on both the donor, the egg donor and the sperm donor. But in some cases, if it's a couple, for example, a 32-year-old couple donating their X-ray embryo, we will probably just have very basic information on each of them. But we are transparent about that, and obviously, if you're not happy with the embryo, you don't move on. Okay, you will only commit to the treatment if you are happy with the embryo that is being offered to you.
Crystal clear, I think. Thank you so much. That will be it for today. But I just want to mention, as always, that remember that if there's if you have any other questions, you are definitely encouraged to just simply get in touch with Ferti Centro and Dr. Vladimiro and his team. And I'm sure they will be more than happy to help you out. And of course, you can see the email address here, but obviously if there's something you wish to ask, you know what to do. You can always email us as well, and you can even email me or Dr. Vladimiro. It's definitely a possibility. I'll be happy to forward any of your emails to the team. We've done it many times and it works. So thank you so much, everyone. It's been a great session. Thank you so much, Dr. Vladimiro. You've been, lots of questions like on different topics, but I think it went very well. So thank you so much for joining. I think that it
Thank
was
you,
a great
Caroline.
webinar. As you can see, everyone agrees here. There are plenty of thank yous as well.
Thank you, Caroline.
Anything
And,
else before we finish?
Yeah, and so thank you, everyone. Thanks for listening. Good luck for all of you that are going through IVF treatments, and it's always a pleasure. Until see you next time, Caroline.
Definitely, we will be back with Dr. Vladimiro and some other events as well, as you know. So go to myivfences.com website. There are more events. We will be back on Tuesday with another topic, some more events as well. So yeah, I can only encourage you to subscribe to our YouTube channel and also go to our website to simply see what else we have prepared for you. Thank you for your time. And obviously, we'll see you here quite soon. So thank you and take care. Good night. Bye.
Thank you. Bye-bye.